Hello, I'm Elizabeth Ward, Senior Vice President of Intramural Research at the American Cancer Society in Atlanta, Georgia, and Chair of the World Trade Center Health Program Scientific and Technical Advisory Committee. Welcome to this program on cancer and the World Trade Center Health Program. Joining me today is Michael Crane, Director of the World Trade Center Health Program Clinical Center and Associate Professor of Preventative Medicine at the Selikoff Centers for Occupational Health at Mount Sinai Hospital in New York, New York. Dr. David Prezant, Chief Medical Officer, Fire Department of New York and Special Advisor to the Fire Commissioner for Health Policy and Co-Director of the World Trade Center Health Program in New York, New York. And Mark Farfel, Director of the World Trade Center Health Registry at the New York City Department of Health and Mental Hygiene in New York. Welcome to all of you. The goals of this program are to explain why the World Trade Center Health Program added cancer to the list of World Trade Center-related health conditions under the James Zadroga 9/11 Health and Compensation Act of 2010, which is also known as the Zadroga Act, to recognize what cancers and screenings are covered by the World Trade Center Health Program, and to identify the processes for determining the World Trade Center relatedness of a disease in a patient with cancer suspected to be due to World Trade Center exposure. The World Trade Center Health Program STAC was established by the James Zadroga 9/11 Health and Compensation Act of 2010. The Act specifies 3 general areas of contributions to the World Trade Center Health Program from the STAC. The Act requires the administrator to seek advice from the STAC with regard to additional eligibility criteria with regard to identifying research needs for the program, whether a particular health condition should be added to the list of World Trade Center-related health conditions.
The STAC recommendations regarding the addition of cancer to the list of World Trade Center-related health conditions. The conclusions were based primarily on the presence of approximately 70 known and potential carcinogens in the smoke and dust and volatile contaminants. 15 were classified as known carcinogens and 37 classified by the National Toxicology Program, NTP, as reasonably anticipated to cause cancer in humans. Although exposure data are extremely limited, the high prevalence of acute symptoms and chronic conditions, as well as qualitative descriptions of the exposure conditions, provided highly credible evidence that significant toxic exposures occurred. The primary chemical constituents of the World Trade Center dust are listed on the next slide. Among the most important and notable are the asbestos, benzene, the high pH of many of the particles, which was quite irritating, combustion products, organic pollutants, hydrocarbons, and heavy metals.
So when we look at the association between some of those contaminants and cancer, we see a strong association with aromatic amines and bladder cancer, a suspected association with prostate cancer. We know from previous studies that heavy metals have a strong association with bladder cancer, lung cancer, sarcomas, and upper airway, nasal, and sinus cancers, and a suspected association with neurologic cancers, kidney cancers, liver, prostate, pancreas, and stomach. So there's real associations that have been demonstrated in the literature based on other exposures.
So the STAC recommended that we figure out which cancers to include by looking at epidemiologic studies in World Trade Center responders and survivors. And we also recommended that we look at the cancers that had been associated with specific exposures that were present at the World Trade Center by the International Agency for Research on Cancer. Great example of that is asbestos. So we know that asbestos was present at the site. So we looked at those, so we would include those cancers that had been associated with asbestos in epidemiologic studies based on an IARC review. Finally, we recommended including cancers that occurred in sites that were associated with conditions that already had been established as World Trade Center related.
Yeah, I think it's important to mention that STAC had a very challenging task in considering this, because in terms of the epidemiological studies on World Trade Center exposed populations. The cancer studies were at the very early stages, and I think there were been a limited number of publications at that point, and the other cohorts were looking at their data but hadn't yet published.
Yes, and I think that's a very important point. We knew even then that it might take 5, 10, 15, 20 years before we could really understand the full extent of any cancers associated with World Trade Center exposures. And so it was even unlikely that at 10 years we would necessarily have a very definitive assessment. And therefore, we had to look at other sources of data in addition to epidemiologic studies. And that was an important basis of why we included the IR carcinogens and associated sites. We also, of course, recommended that as the new epidemiologic studies were completed and published, that the results of those be reviewed and, if appropriate, cancers be added to the list. And we recommended that since some cancers may be affected by early detection, the course may be improved by early detection, that the World Trade Center Health Program provide funding for cancer screening.
I think it's true to say at the time, and still true, there was intense public interest in early cancer findings related to 9/11. And I know that the World Trade Center Health Registry, when we met with community and labor advisors, was certainly something that came up early on.
The administrator took the STAC's recommendations under consideration, as well as other sources of information, and he established a method by which cancers would be added to the list at that time and in the future. And the first method 1, was that a cancer may be added to the list if peer-reviewed epidemiologic studies found a causal association between that cancer and exposure to 9/11. We all knew that that would probably be a difficult condition to satisfy, but of course it's important that it be there. The second method defined by the administrator is that a cancer can be added if there's a well-established causal association between that cancer and a condition already on the list of World Trade Center related conditions. So the World Trade Center also considered a method where he would use the criteria for establishing cancer sites from IARC. So the IARC review finds an association between benzene and leukemia and lymphoma, and that site could be added based on that IARC review, as long as benzene was an exposure, a documented exposure at the World Trade Center. And finally, the administrator allowed for considering any additional information that was provided by the World Trade Center's Health Program STAC.
Okay. So what cancers are actually covered by the World Trade Center Health Program? Childhood cancers, of course, and other common cancers in adults. Prostate cancer was added in 2013 when new studies came out showing that all 3 groups have demonstrated an increase in prostate cancer. And the STAC had the foresight to recommend that rare cancers be covered because epidemiologically we may never have enough of those to demonstrate a true association. Are there cancers that are covered that we didn't realize at the time? Yes, if they're rare, as we define by an incidence rate of less than 15 cases per 100,000, they are subject to being added to the program if the administrator so chooses. And there are a whole bunch of cancers that would fall into that group, such as very unusual cancers of the adrenal glands, of the lower GI canal, breast cancers among men, already covered among women, but very rare among men and uncovered, gallbladder cancer, brain cancer, pancreatic cancer, thymus cancer, and many others. Neuroendocrine cancers, no matter where they appear, they're called neuroendocrine, but they can appear in other organs that aren't typically related to the neurologic system. And in addition to the hematologic cancers, they added in the myeloid neoplasms, which are precursors for many of these cancers and are now covered very importantly.
Well, given, as I said earlier, the intense public interest in possibility of early cancer effects following 9/11, the cohorts had actually anticipated these analyses and discussed early on how to approach assessment of cancer in the cohorts. And each cohort did an initial look based on data through 2008 and published those findings. And the first published findings actually came out from your cohort, Dave, the fire department, followed by the registry and the consortium, World Trade Center Health Consortium, in 2012 and 2013. And what's striking about all three studies is, one, that there were actually methodological differences. The differences included recruitment strategies, exposure assessment, the demographics of the populations, the handling of latency, and the length of follow-up. And despite all of these differences and others I haven't mentioned yet, the studies did arrive at similar conclusions. I think we're all in agreement that the presence of these three cohorts actually strengthens our work to identify and quantify cancer risk related to 9/11, and that these differences in design across the three studies may actually elevate the sensitivity of the research for identifying cancer risk related to 9/11.
I think a hallmark, landmark foundation of causality research is to be able to reproduce those findings in other cohorts.
In different populations.
And the fact that we've done that is probably the strongest evidence that there's really an association with cancer.
So what we'll get into next is we're going to talk about a little bit of the details from each of the three early cancer studies.
Great. So the first study was in New York City firefighters and EMS workers, but we concentrated in this study on the firefighters. It was a study of nearly 10,000 male firefighters who had been employed at the fire department since January 1st, 1996, because one of the unique aspects of the fire department is that we're able to not only look at what's happened since 9/11, but compare it to what happened in this same cohort before 9/11. When we compared to the general U.S. male population, there was an increased incidence with a SIR, a standardized incidence rate of about 10% above normal, 1.10, in our World Trade Center exposed firefighters. But when we compared it to our non-exposed firefighters, since we started the study in 1996, or defined the cohort starting in 1996, we saw that the SIR was increased by anywhere from 19% to as high as 32%, depending on the statistical methodology we used. So we found a modest excess of cancer cases, but a real excess. And we're cautious in interpreting these findings. We need those long-term studies, especially when it comes to identifying the individual cancer types.
So the second study was conducted by the World Trade Center Health Registry, and this was a large observational study. We focused on the New York State residents because most of our enrollees actually lived in New York State at the time of 9/11 and continue to do so. So we included in the first look almost 56,000 New York State residents who were enrolled in the registry in 2003 and 2004. And we looked at people who were at risk for a first primary cancer at the time of their enrollment in the registry. Now we also, to find the cases, we did link our registry to the New York State Cancer Registry, but we also included 10 other state cancer registries, and we did that in order to be able to identify cases that occurred among residents of New York who moved out of state, and those 10 state cancer registries covered about 95% of all our enrollees. And the second hallmark of our study was that we chose to focus on the cancers that occurred in 07 and 08 because we believe that during that time period the cancers more likely to be related to 9/11 exposure than the cancers in the enrollees that may have occurred during the first 5 years after 9/11. So similar to the fire department findings, when we looked at this later 2007-2008 period, our standardized incidence ratios among responders in the registry were elevated for prostate cancer and thyroid cancer. We took a look to see if the intensity of the exposure was related to the occurrence of these specific cancers, and we did not find a statistically significant association. However, when we looked at the hematologic cancers that you spoke of earlier, we did find a trend that was not statistically significant, but a trend of increasing risk with increasing 9/11 exposures. And like you, Dave, we also came to a conclusion that the relatively small numbers and the short period of follow-up, that we were cautious and that we really highlighted the need to do longer-term follow-ups as really the key to this whole analysis.
I guess we'll be saying this again and again, but this is very, very early in the stage of a possible cancer development from any occupational exposure. 5 to 7 to 8 years is barely in the door for the beginning of cancer from an occupational exposure. So we'll keep on saying that. At the consortium study, which was the solely of responders, we looked at cancers among almost 21,000 World Trade Center members, found 575 cancers. Elevation of incidence ratios in thyroid cancer, prostate cancer, combined hematopoietic and lymphoid cancers, and some soft tissue cancers. Again, interpret these results with caution because of the very short follow-up period. And there may be also changes in future populations because of the small numbers we found could not be considered predictive of the future. But in general, substantiating the elevated risk of cancer for this population found in the other two studies.
So this next slide summarizes the results of the 3 studies side by side. All 3 studies found a modest, either statistically significant or nearly statistically significant excess in risk. For another really important point is that for lung cancer, which is one of the most common cancers and one that's often associated with occupational exposures as well as smoking, we did not observe, none of the 3 studies observed an elevated risk. The other cancers that are listed on this slide are cancers that were in excess was seen in 1 or more of the studies, and I'm struck when I look at it by how consistent it is. You know, melanoma was seen in 2 of the studies. It wasn't seen in the 3rd. Excesses in prostate and thyroid cancers were seen in all 3 cohorts. Now that's one where many epidemiologists would have a concern that these cancers are appearing in part because of screening and early detection. And we can never be really sure about that because people who are in the health program specifically would be seeing physicians and more likely to get screened. The other cancers, I think, are very significant because the hematologic cancers are cancers that are likely to arise with short latency. And so the fact that we're seeing excesses in non-Hodgkin's lymphoma and multiple myeloma may be a really important signal that we need to look at carefully in the future.
Elizabeth, the fact that we're not seeing elevated lung cancer by now doesn't mean there's no risk. Is that correct?
That's exactly correct. So lung is one of the cancers which tends to have a longer latency. We really need to look long term, and we also need to compare the highly exposed to the less highly exposed. The general population may just not be a good reference group for these very unique healthy worker populations and survivors.
We're going to talk a little bit in pragmatic terms now about how folks get covered for cancer and how their cancers get treated in the World Trade Center program. Among the things that must occur under the Zadroga Act is individuals have to have their cancers, quote unquote, certified. And to have your cancer certified, you must first of all be an individual who's enrolled in the World Trade Center health program. The certification requires that the member have a cancer that's on the list of World Trade Center related conditions that you've just seen, a determination by a physician involved with the World Trade Center program that the individual's exposure was substantially likely to be a significant factor in aggravating an underlying condition or causing that cancer, and the approval of the World Trade Center Health Program Administrator that is in fact a World Trade Center related cancer. NIOSH then certifies that cancer as World Trade Center related.
You know, I think it's important to note that this is an independent review. So the World Trade Center Health Program, who typically is not actually treating the cancer,
correct,
all right, is looking at all the medical evidence, both for the exposure and for the disease.
Yes.
And has to come to that conclusion of substantially likely. But even then, an additional review is done at the federal government level by physicians who have never seen the patient, who have no relationship with the patient, and likewise feel that this is consistent with the STAC's recommendations and with the federal regulations governing the program. So this is a very responsible, careful decision because we know the enormity of it. We know that these people now are covered under this program.
What you'll see now is a matrix about exposure and cancer coverage. It is not really complicated. Our exposure assessment depends upon a couple of factors. We had no measurements on site of live coverage of the dust cloud. So our assessment depends in many instances on the time the individual patient arrived on the site, how long they were there, that's the duration of their exposure, and the nature of that exposure, chiefly involving what type of work they were doing or what kind of living condition they had. And you can see it depends here. If you were there on 9/11, a minimum exposure for an individual to be considered if they had a cancer develop is about 4 hours. If they arrived at later times when there was less dust in the air and a little bit more controlled conditions, that exposure could be longer, and you'll see that in the chart.
So in addition to the intensity of exposure, the World Trade Center Health Program established criteria of minimum latency periods for different types of cancer to be certified. And they did this based on what's known from the epidemiologic literature. But the idea of establishing the minimum latency was to really determine that there was a biologically plausible, scientifically, valid association between the exposure at the World Trade Center site and the specific type of cancer.
In terms of being proactive, thankfully this program also covers cancer screening. And we follow the guidelines of the U.S. Preventative Service Task Force. So we cover cancer screening for anything that's rated a grade A or grade B by this task force. So in addition to treating the cancers, we're actually screening for cancers and trying to find early disease when we can best do that.
Well, the World Trade Center Health Registry was actually designed to track the long-term mental and physical health impacts of 9/11 and also unmet healthcare needs. However, we're the one cohort program that doesn't provide direct clinical care. However, fortunately for us, like the clinical programs, NIOSH, World Trade Center Health Program, has empowered us with tools to reach out and link our enrollees to the World Trade Center Health Program. So basically we have our enrollees report their health symptoms and conditions to us periodically on our periodic health surveys and their unmet needs, and we contact those people who report 9/11 related symptoms and we try to encourage them to enroll in the program.
So I'd like to summarize the key messages and lessons learned from this presentation. And the first one is that based on the presence of carcinogens, some responders and survivors may develop cancer from their experience. We don't know how large the risk is. We don't know for sure what cancers will be affected. And it's quite possible that most people who were exposed to the World Trade Center dust will not develop cancer as a result of their exposure. But as you've heard today, there are good studies in place so that we can identify those increased risks if and when they occur. And we also have programs in place to help people in terms of identifying the cancers early, possibly detecting some cancers and getting treatment. Because many cancers have long latency periods, we've emphasized that throughout, it's extraordinarily important that people who are enrolled in the World Trade Center Health Program continue to be monitored and offered screening and early detection, and that research continue. In addition, even if a person is not currently a member of the World Trade Center Health Program, they can apply to the program to be certified as a cohort member and be eligible to receive cancer screening. That's a very important benefit that I suspect many people may not be aware of. And finally, I think it's important for everyone treating patients who may have cancers related to their World Trade Center exposure to understand that approved cancer treatment is covered by the World Trade Center Health Program if the person's cancer is deemed eligible by the administrator, and that person can receive treatment provided that where they want to receive treatment is authorized by a World Trade Center physician.
Exactly.
And the World Trade Center Health Program is collaborating with many highly qualified oncologists and health centers, so the treatment that a person receives will be top-notch.
Absolutely.
You know, I think you bring up an important point to the listening audience, that this is not just a New York City problem. In every state of the nation, in almost every congressional district, there are people living right now who have been exposed to the World Trade Center in any of the ways that we've previously described, and an oncologist or a primary care doctor, a gynecologist, may see those patients and may forget to ask, were you exposed to the World Trade Center, because they don't live in New York State. Every time we diagnose somebody with cancer in this country, we should know what their occupational and environmental exposures were.
Absolutely.
And we should add to our question list, were they exposed to the World Trade Center? Because that opens up a whole potential for us better understanding the disease, as well as offering treatment to that individual.
Absolutely.
Absolutely.
So there are some resources available for finding out more about the program, the World Trade Center Health Program. And finally, there's more information about the World Trade Center Health Registry at their website.
You can find summaries of all the registry's research on physical and mental health outcomes on the website, including brief videos with authors of our papers reporting on findings, and enrollee testimonials to give you an idea of what's on their minds as well.
I'd like to thank you for participating in this very informative and interesting discussion today.
Thank you.
Pleasure.
Thank you. We enjoyed the opportunity.
And thank you to our viewing audience for participating in this activity. Click on the Earn CME CE credit link to take the CME CE post test. Thank you again.